So good morning, everyone. It's a beautiful morning here, and welcome to another edition of the Global Medical Physics Education Series. My name is Fumi, and I'll be standing in for Dr. Joe for today's education series. So today we'll be having Dr. Mike Lauria as our speaker today, and we will be talking on the breathing motion dynamics in lung radiotherapy. So I'm going to give a brief introduction about our speaker for today. Dr. Mike Lauria is a medical physics resident at the University of California, Los Angeles, where he also completed his PhD studies. So he's here today to discuss his work with biomedical modeling and its role in radiotherapy, both present and future. So, Dr. Mike, welcome to this Radhead Oncology series, and we are happy to have you. So you have the floor. If you have any question, please, you can use the chat box. There'll be question sessions at the end of the meeting that will be like interactive. So you can put your question in the chat box during the course of the lecture, and also you have the opportunity to ask your question directly after the teaching. Thank you so much.
Thank you for the introduction. So I understand that the last few talks were about motion management, but I do want to reassure you this will be very different. Instead of talking about things that are currently just clinical practice or clinical guidelines, I want to talk about some of the research that we do here. We have a very big research program in motion management, so I want to let you know what kind of things we're working on, what are some future visions, and even some research projects that have become clinical practice here at UCLA. So I know that was a great introduction, but I'll include a little bit more background about myself. I'm actually from Western New York, and then went to Purdue University, where I studied nuclear engineering, as well as mechanical engineering and Italian studies. So I've got a little bit of a diverse background before entering medical physics. I came into medical physics here at UCLA at our graduate program, phenomenal graduate program, and then stayed here for my medical physics residency, and I'm currently in my second year of that 2-year program. And so here at UCLA in grad school and still today, I've been working with Dr. Daniel Lowe's lab. These are just some members that I've worked with, present and former. Dr. Dylan O'Connell is currently faculty here at UCLA. Dr. Anand Santanam was faculty here, but now he works for Siemens AI. And then these are some students that I have worked with before and a little bit currently. So I'd just like to start off with this slide so you guys can see all of the brilliant people that help make all of this work happen. And so in our lab, we focus on motion management. This is probably a review from the last couple talks, but basically our objectives here are to compensate for tumor motion so that we can create smaller target volumes and therefore decrease radiation to normal tissues. In some ways that they probably discussed how we do this clinically, you can do this with breath hold CT. So you can take a breath hold CT at exhalation or at inhalation, and then you can kind of capture the motion, still motion. But you don't really get much dynamic information from that, just kind of 2 snapshots. And most importantly, it can be difficult for sick patients. In radiation oncology, we care for sick patients, so this issue is quite common. Now, 4D CT is something that is also very conventionally used to address this. We let the patient breathe freely, and then we sort repeated images into breathing phase bins. We reconstruct each bin, so we have these phase resolved images. But in cases of irregular breathing, we can see drastic artifacts. So you can see in this example here of a clinical 4D CT that we took, this kind of stamping effect. And so again, patients in radiation oncology often breathe irregularly, so it is a common problem. So something that Dr. Daniel Lowe has worked on for a long time and has become clinical practice for us is this 5D CT. So it was created to address specifically those sorting artifacts in 4D CT that arise from irregular breathing. Now, The way it's done is entirely different. Instead of phase binning, we use motion modeling. So you relate tissue displacement or kind of track the tissue across different images. You relate that to the breathing amplitude and rate, which is acquired from a surrogate signal. So then you can fit the motion of those voxels to the changing breathing patterns. And then once you have that model, you can create any phase images. So you can recreate those phase bin images from 4D-CT. So in this case, we have that same 4D-CT example, and then here is it reconstructed with the 5D-CT. And I've got a little bit more detail in this flow chart here. So the way we do this, we acquire 25 just fast helical free breathing CTs, patients just breathing freely. At the same time, we have this surrogate, which is like a belt that goes around the patient's abdomen. And as that belt expands and contracts, we can measure that pressure difference as a signal. So then we have the amplitude and we have the breathing rate all throughout the images. So we take those images, we call the first one the reference, and then we have 24 like moving images. So then we can use image registration to track the voxel from image 1 into the 24 other images. Then we fit this motion model, and we can generate any phase images that we desire. And clinically, we reconstruct the same phase images as 4D-CT, but in practice, we can reconstruct any image. Just want to check in on the chat here. Okay. So the first publication I could find from 5D-CT was in 2005. I'm sure plenty of work went into it beforehand. Then years later, in 2013-14, we saw some more publications developing the technique, making it closer to something we can use. And then 2015-2018, Dr. O'Connell and Dr. Lowe performed a series of validation feasibility studies that could bring 5D-CT to the clinic. And then I was lucky enough to be a graduate student here in March of 2019 when we scanned our first clinical 5D-CT patient. So in 2019, this became something that we use clinically. In 2021, we had scanned about 100 patients. And then this past year, we passed about the 200 mark. So I'm going to talk today about a series of projects, but the first one is a reflection of our experience with this 5D-CT approach. So for all of our patients, we stopped doing 4D-CT and we started doing 5D-CT. And what we're doing here is kind of pausing the program, reflecting back and seeing what's working, what's not working. Are we addressing the issue of irregular breathing that we set out to address? And the rationale here is that, we can improve it as we go forward if we keep taking these breaks to look back and correct. So the workflow of this study, we reviewed these patient QA reports. So every time we perform a 5D-CT, we generate a whole QA report, and I'll show some examples. Then we graded the workflow, different workflow things like registration, breathing regularity, and we also graded the model accuracy on this 1 to 4 scale that I'll elaborate on. And we correlated those workflow predictors to model accuracy, and then also investigated clinical usability. So how often are the physicians using 5D-CT, and can we determine if it's a success or failure in each case that way? So this is a non-exhaustive, but just kind of the key elements or example of those patient QA reports. So first we have the respiratory surrogate. So again, this is coming from that belt that the patient's wearing during the scanning. And we annotate the exhalation, which we call 5th percentile, and the inhalation, which can either be 85th or 95th percentile, but we've been calling 95th percentile amplitude the inhalation. Then we have a summary of our image registration. So registering that first reference scan to the 24 moving ones. What these images are basically green and purple images overlaid. So you have your registration of, let's say, 1 to 2. I can put 2 back into 1 with that map. And if the map is good or the registration's good, they'll overlay and those colors cancel to grayscale. So you'll see like a little bit of green throughout here. that's a mismatch. So you can kind of see like purple and green just very easily visibly where did it go wrong. I'll show some various examples, so that's exaggerated. This is a pretty accurate case. And then we do this validation, which is something that they came up with for this. So we have our model. How can we tell that it's actually working? Well, we can take our reference scan in our model and recreate the 24 other scans because those are real ground truth scans. So if the model works, we should be able to generate those. So again, we make those images and overlay them. And you can see where green and purple are mismatches right here. It's gas in the bowel exaggerating that, but in the lungs, it's very accurate in this case. So then we did this grading process, which is adapted from one of the validation studies, where basically a grade of 1 is no anticipated clinical impact, no errors. So in the case of breathing, we consider this very regular, would not create errors. Image registration, very accurate, and validation, very accurate. And then over leading up to a grade 4, we have high breathing irregularities that we anticipate would cause major errors in 4DCTs. Very inaccurate image registration and very inaccurate validation. So you can see here like an example of those mismatches being highlighted by the green and purple images misaligning. So then we looked at how do these things, work together. So first we looked at image artifacts just in the images. So sometimes with these free breathing images, if the diaphragm moves too fast, it kind of gets stamped several times and that can create issues. But luckily we didn't really see many, drastic artifacts. But when we did, they did create issues in the 5D-CT. So that's one identified factor. Then looking at the image registration, as on the top, we're going 1 through 4. On the rows, we're going 1 through 4 with the validation. And then these are frequency, like 2D heat maps or histograms. So we're seeing, a lot of density on the diagonal line here, indicating that as the registration gets worse, the 5D-CT performs worse. But on the other hand, with the breathing irregularity, we don't really see that diagonal relationship. It's kind of just clustered here and mostly lower grade validations. So putting numbers to these, we could see correlation coefficients as well, where the image registration is correlating highly and the breathing irregularity is the least correlative predictor. So we're seeing least sensitivity to breathing irregularity. Then looking at the usability, what we did was we went back through the contour sessions. We looked at, what happened. What did the physicians use? Did they use the 5D-CT for contouring? Did that fail and they had to go to our backup? Or was the patient put on a different device, like the MR-Linac, where they don't need the ITV contour anymore? So basically, we could kind of see what happened and how well did 5D-CT do in the eyes of the physicians. And so we saw that 80% of the time, the 5D-CT was used for contouring the ITV. And then 3% of the time they were moved to the MR-Linac, which I think is also successful because that decision was probably based on the 5D-CT motion. So only in 12% of cases did we see that they had to jump to a backup protocol, which we have two different kind of flavors of that. But basically, we saw overall high efficacy, but still room for improvement. So in summary of what we're doing with this reflection study, we looked at the impact of the artifacts, registration, and breathing irregularity on 5D-CT accuracy and found that the reconstruction accuracy was least dependent on breathing irregularity, which is great because the goal of 5D-CT was to address those specific cases of breathing irregularity. However, we're discovering that with this new technique, we have a new importance on image registration accuracy that really is largely driving the accuracy in the 5D-CT. So for future directions we want to roll out this new and improved 5D-CT based on this experience, and that's probably going to largely come from improving the image registration. Part of that is which image registration algorithm do you use? We picked one some years ago, but there's a lot of research in that space, so there's probably a lot of room for improvement. So that's a large effort of ours. Um, but also, it doesn't even have to be the algorithm. You might have a strategic way of picking the reference image, and different ways to try to make the registration an easier task. So these are all things that we're working on and kind of new considerations with this new approach. Um, but what I want to talk about a lot today, that was kind of the clinical aspect, but where does all this go? We have this motion model based on CT simulation, and it can do a lot more than reconstruct sim images. So I want to talk about kind of a larger vision that all this motion management and research is working towards, which I think I mean, there's many different things, but one that I think is very interesting is this idea that we could adaptively minimize the dose to functional tissue using this motion modeling and functional mapping. So what this might look like with kind of all these different areas of motion research. First, we have our motion modeling from CT Sim, which might be your 5D CT. In our case, it is 5D CT. Then you could use that to actually calculate regional lung function like ventilation, elasticity, and tissue stiffness, and get a regional map of how well the lung is actually functioning, how healthy it is. And then that way you could avoid it when you plan your treatment plan. Um, and this is something that people have investigated, but another new aspect we could throw in here is motion modeling in daily imaging. So you can take your motion model from CT Sim, and I'll show you a study where we showed that you can actually use that to compensate motion in the cone beam CTs. And so if you have a motion model every day, you can do this regional lung function mapping every day and monitor changes in the healthy tissue. So this is a future vision, but this is kind of some of the stuff that we're working towards. And so I'm going to break these down into, how we're working towards that vision. So with the CT, we talked about the 5D CT, that's that component. So I'm going to jump over to the regional lung function mapping and what kind of work we're doing there. So this is going to be broken down into two primary studies, parallel studies. They're very similar, but focusing on two different functional metrics. So the first one is ventilation. And the goal of our project here is to characterize the heterogeneity of ventilation in patients specifically with COPD, something that drastically changes lung function measurably. And characterizing the heterogeneity is how we can take advantage of it in treatment planning, identifying areas of high and low ventilation and knowing when those things might change or might be worth planning for. Yeah, and the rationale here is that we can offer comprehensive functional guidance during planning. So when I talk about ventilation, in this case, I'm referring to gas transfer leading to gas exchange. And we can calculate this from CT. Other groups have shown this. Dr. Richard Castillo has done a lot of work in this, Dr. Kipriditis, and I'll show some other examples, but it's a pretty, popular research topic. So one way you can calculate ventilation from CT is with the deformation vector field. So if I register image 1 to image 2, I can use the map or the vectors that map 1 to 2. I can use that to calculate ventilation because I can measure the expansion of it. I can use the density ratio from image 1 to image 2 because the density in the lung voxels should only be changing due to changes in air content. I mean, at least in terms of practical measurements. So we can see the density ratio and measure the change in ventilation. And then we can also just look at the volume change in those voxels or in larger structures. So if the lobe has a volume change, we can use that to measure ventilation as well. And it's following kind of the same logic as the density ratio. So as I mentioned, there's other groups working towards this, and this is what motivates us. So Dr. Yamamoto and Dr. Vinogradsky have done a lot of work showing this in practice. So first, they ran a study where they showed that they could reduce the volume receiving 20 gray of the functional tissue, so showing that it's feasible to plan around. And then they actually did this in a couple of clinical trials, and it led to a reduction in grade 2 and 3 pneumonitis. So they're showing that it does make an impact. But we think that the statistical details of the heterogeneity are still something we can learn about. And I think that will tell us when is it important to put this in practice for a patient. So there's still kind of a caveat to all of this, which was highlighted by this vampire challenge. I love including the vampire challenge in all my talks because I love the name, but also because it's really a beautiful display of this problem that we have in our space. So the way that this works, they basically took a data set, sent it out to all these clinics and said, calculate the ventilation and send us back what you get. So you can see here how different all those results are. So it's not a very straightforward calculation. I showed you I listed 3 ways, but there's actually even more ways you could calculate ventilation. So there's a lot of heterogeneity just in our approach and even in the results. I mean, I think some really good examples are looking at number 18 here versus number 22. I mean, you have different levels of resolution. You have different identified areas of high and low ventilation, which would be problematic for this because you're avoiding the wrong tissue. So what we did to kind of address that in our study was take our data and calculate ventilation 2 separate ways. Tough thing is you don't really have a ground truth, so you got to kind of come up with a way to give yourself either an uncertainty analysis or some kind of confidence. So we came up with 2 different approaches with the same data and then evaluated the consistency in those. Then we compared, to execute the study, used one of them to compare the ventilation across the lungs and across the lobes. And we did that in different COPD severity groups where we know there should be a measurable change in lung function. So the 2 ways, tried to make them 2 different categories of ventilation calculation. So the first one, which I call 5D ventilation imaging or 5D VI, we use the 5D CT model to generate inhalation and exhalation scans. And then we just take the volume ratio, either of the lungs or of the lobes, and that is representative of ventilation. On the other hand, we went with the DVF style approach, and we call this free breathing ventilation imaging or FBVI. So we have our reference scan registered to the 24 other scans, and we calculate the Jacobian of those of those vector fields. Now the Jacobian is the determinant of this matrix. Looks like a lot of gradients and a lot of numbers, but really what it is the expansion, right? Vectors expand out, and this determinant will capture that expansion. And so we have 24 examples of those, so we can fit those 24 expansions or Jacobians to the amplitudes and the slope of that fit. So as the amplitude changes, how does the expansion change? That tells us ventilation as well. So 2 very different approaches. One uses modeling, one has no modeling. One's volume, one's based on vectors. So this is kind of how we gave ourselves more confidence in our measurement. And so looking at the consistency in those, we did this Bland-Altman analysis and found that the mean difference was 0.01. So, okay, ventilation 0.01, is that high, is that low? What does that mean? Well, these are kind of like percent volume changes. And in a full breath, that might be around 20 to 30% volume increase. So we're consistent around 1%. So pretty accurate. And for the rest of the figures, the differences of each data point to the mean, these are all different patients, different lobes. So the distance to the mean is going to be our error bars. So now we say, okay, we have some confidence that we know these are pretty consistent, but also we have a measure of how different are they. So then we looked at the ventilation between the lungs, which we thought was pretty interesting, especially for patients that might receive a valve or some kind of surgical procedure. You might want to know the difference between lung ventilations. So we saw, tendency towards the left lung ventilation. This black dotted line is basically 1-to-1, perfectly symmetrical. we didn't see anything statistically significant, and we didn't really see much of a difference between the COPD severity groups, which are no COPD, mild COPD, or moderate to severe COPD. But looking at the lobar differences, we first looked at the contralateral lobe pairs, so like upper versus upper, lower versus lower. We saw pretty symmetrical ventilation. But then when we looked at the ipsilateral lobe pairs or the adjacent lobe pairs, we saw much bigger differences. So that might be where you want to identify high and low ventilation. But what's perhaps more interesting than either of those things is that in all these cases, the moderate to severe COPD group demonstrated a much higher heterogeneity in ventilation. So we're seeing this COPD create this functional heterogeneity. So I mentioned that we didn't have a ground truth, but just this past year, we came across a patient that came in for 5D CTs and also had spec-based ventilation scans. So this actually is a clinical technique where they have this technetium 99 and they can actually measure ventilation and perfusion with these scans. So we finally have something to compare with. It's one patient, but it's finally some kind of benchmark. So the patient had 2 scan sessions. The ones that we had 5D CTs for are November and June, so a lot of time in between them. And they also received brachytherapy and SBRT in between, so some induced changes as well. So looking at the SPECT versus, well, we use the FBVI in this case because it could be done regionally. So top 2 are scan 1 and the bottom 2 are the second scan session that we had. You can see some qualitative consistencies, low ventilation in the inferior posterior region, similar hotspots of ventilation in the 2 different techniques. So, okay, that's great. It looks consistent by the eye, but we should be putting a number to this, right? So we did that here. And the way we wanted to put a number to it was in the context of functional sparing treatment planning, where we want to be able to define what's high functioning tissue and what's low functioning tissue. What should we avoid with radiation if we were planning? So these plots show on the x-axis different thresholds for high ventilation. So in, for example, the 40, we're saying higher than 40th percentile ventilation is high and lower is low, and we create contours of those. Then on the y-axis is the dice score similarity between the free breathing VI and the spec-based. So you're basically comparing how much of the volume of those contours overlap if I use our method or if I use the SPECT method. And so if you consider 0.7 as a pretty good dice score, that'd be like 70% of the contours overlap. We can get pretty consistent results using a threshold of about 50% or 50th percentile ventilation. I think that's a pretty nice, intuitive, and useful threshold. But what happened in the second scan session is that was reduced a little bit. And now a lot happened, a lot of treatment. So still trying to, I think we need a lot more patients to investigate this. This is our early experience, so there's some promise here. But I think we need to have more before and after treatments and see, is this the induced changes or is it just one case? But anyway, this is the beginning of our efforts to compare this to SPECT-based. So in summary of the ventilation study, we developed these 2 independent ventilation calculations that give us a dual confirmation without having a ground truth for those cases. We found evidence of higher lobar ventilation in patients with severe COPD, which I think is useful guiding information for how can we know when to enroll a patient for function sparing treatment planning. And then early comparisons to spec-based ventilation show that perhaps 50th percentile ventilation might be a reliable threshold, but in the future directions, we need to process more patients to really determine that. And I'd also like to compare to breath hold images. I think that gives us just another benchmark to say for the same cases, are we getting consistent ventilation results? And I think once we really nail down that confidence in the technique, then we can try to start applying to functional avoidance therapy here at UCLA. And then kind of switching over to the other biomechanical metric that we can analyze, or we've investigated in our research group, is tissue elasticity. So same kind of project goal and rationale, but new biomechanical metric. So the way we define elasticity here, it's basically the stiffness of the tissue. We define it as the Young's modulus, which is the relationship between stress and strain. So the way we can kind of get that from CT is with this inverse model, where we take all the voxels and kind of call them like particles. And all those particles are connected or simulated to be connected by a spring so that we can measure the stress strain relationship. And then we use this kind of inverse model where we have our DVF is calculated, or our vector field is calculated from the 5D CT, same one that we've been talking about before. And then we set an initial elasticity distribution. We basically use the model to calculate from elasticity of model generated vector field. And we compare that to the one we gave it. And if they don't compare, we update elasticity. And then we do that over and over until they converge. So there's some details if you refer to Caitlin Haas, her publications, and also Dr. Jack Nalen here at UCLA. They've done a lot of work in developing this and validating it, and even using it as a metric to grade COPD as well. So there's been a lot of awesome work by them. So we're going to use it to look at the heterogeneity of COPD in this case, or of lung function, but in cases of COPD. And so this flowchart kind of is basically the same thing as the ventilation. We're going to use our image acquisition, fit our motion model, get our vector field, calculate the tissue elasticity, and then analyze the heterogeneity across and within the lobes. So this is just a visual example of a couple of cases with the elasticity on the right. And these are the exhalation and inhalation images. So the top one's an example of high interlobar heterogeneity. You can see kind of across this lobe fissure here, a vast difference in heterogeneity, or a vast difference in elasticity. And then down at the bottom is one that's less heterogeneous between the lobes. So you see kind of different spread out regions of elasticity. And so we looked at the heterogeneity across different lobes. And so we can see, kind of the changing relationship between the lobe and elasticity, where we see high elasticity in the lower lobe, which makes sense. It has to do a lot of the work. But then also we saw as the COPD severity increased, elasticity generally decreased, especially in these severe cases. And those differences were statistically significant between the moderate to severe cases and all the other cases. Lobes. We did this by measuring the coefficient of variation of the elasticity. So the standard deviation normalized by the mean. And we saw, well, these are histograms of those coefficients in the different COPD severity groups for all lobes considered. And we saw significant differences between, again, the moderate to severe cases and all the other cases. So that gave us a sense of the typical heterogeneity, but we wanted to get a measure also of the extreme differences. So we looked at the non-uniformity index, which basically compares the 95th percentile value to the mean. So how far can it get? And these violin plots kind of show how that changes over the lobes. These different plots are the different COPD severity groups. And then each subplot or each violin is the different lobes. So it's actually reduced in the lower lobes. But what I think is the important takeaway is that they're all pretty much around an average of 1. And if the average is 1, then that's showing that elasticity can be twice as high as the mean in any given lobe in any given circumstance. So we're really just trying to characterize the heterogeneity. How does it look and how can you look out for it? So in this study, we characterized heterogeneity and elasticity and its presence in patients with COPD. And we saw significantly higher heterogeneity in patients with moderate to severe COPD and with COPD in general. Um, so I think that the most interesting future direction of this research, if you kind of take the elasticity in parallel with the ventilation, you're getting a full picture of the lung function, but there's still one key thing missing, I think, and that's airflow and how is airflow restricted? And airflow is going to lead to that gas exchange. Um, so it's going to lead to the ventilation and it's going to create forces back on the tissue, which interact with the elasticity. So if we can start working towards like an airflow model based on computational fluid dynamics, can really get that full picture. And so we've started working on this a little bit, but I think when we set out to do it, we kind of thought, well, we'll add the airflow model. But realizing that the geometry you use for airflow modeling is very, very sensitive, requires high resolution, and is really the first step before we can get there. So we came up with a method that is like a geometry creation for airflow modeling, specifically for the tracheobronchial tree, because we saw a lot of general meshing techniques kind of can't handle that geometry to the standard that airflow modeling requires. So we came up with a way to like track and characterize the tree and then mesh, with a focus. Um, but there's still a lot of work to do to introduce the airflow modeling with that geometry. So that's kind of where we're going with this. So then you would have this whole picture of lung function. But can we do that every day so that as we're treating the patients, we can actually track how is this changing? And could we even adapt the treatment plan to account for those changes in lung function? So now I'm going to talk about that project. And I think one key thing about this project is it does play into this vision, but it also serves a more immediate purpose, which is reducing imaging artifacts and motion artifacts in cone beam CT every day. So there's a kind of a close and far motivation to this project. So just a quick summary of this motion problem in cone beam CT. We often use just 3D cone beam CT, but in circumstances with motion, there's duplication artifacts. So um, this group did this phantom study where they showed as the phantom has these different motion characteristics introduced, it goes from looking pretty good to looking very blurry, especially in the motion axis. Now, 4D cone beam CT is something that's been well investigated and used in some clinics to address that problem. And it's just like 4D CT. You're retrospectively binning the projections so that you can reconstruct phase bend images. However, it's not like 4D CT where you can continuously take these slice projections. You have one complete rotation, so you don't have a lot of sampling in each bin. So you can see that the motion in the SI direction is reduced. Those motion artifacts are reduced, but now the image quality has greatly suffered because you only have a limited number of projections in each bin. You have to take all these projections and spread them out. And then additionally, you still have the irregular breathing problem, and we're still caring for sick patients. So that's not going away. So some members of our group came up with this MixArt approach to address that issue and introduce motion modeling into the equation here. So the way this works, MixArt stands for Motion Compensated Simultaneous Algebraic Reconstruction Technique. I think the key word here is simultaneous. So you're starting with your 4D cone beam CT. You have those phase bin images. You fit a motion model because you can track the voxels across the bins and you know the amplitudes. So you can make a motion model. And then what they did from there was iteratively update the model and reconstruct the images. However, it took a lot of iterations, and that can be time consuming for clinical workflow. But I think more importantly, the issue is that it relies on a model based on that 40 cone beam CT, which suffers from all of those undersampling and irregular breathing artifacts. So our goal here was to develop an improved cone beam CT workflow using an a priori model, a model that we acquired during the 5D CT simulation. Can we translate that model from the sim to the daily imaging and therefore have a model based on much, much higher quality imaging? And so, like I said, the rationale is kind of close and far. We can offer a more accurate setup just for regular radiotherapy workflow, but having that motion model every day could lead to daily biomechanical modeling. So we have this proof of concept study design where we came up with this idea, but we want to prove that it works. Again, we're always left with no ground truth, so we have to come up with these kind of ways to validate these things. So we have this is the workflow for kind of the reconstruction and the proof of concept. So we have to align our geometries and then calibrate this model. We have this motion model from sim, but it's based on the breathing waveform from sim, which could be different. So we came up with a way to calibrate it to the cone beam's breathing waveform. So you have kind of two very different patterns and one model. We use basically the diaphragm position to say when are those equal and use that as a calibration. Then we applied the 5D model during this mixed art reconstruction, now that it's been calibrated for the cone beam's breathing waveform. And then we needed to prove that it worked. So what we did here was kind of introduce errors intentionally and then control the accuracy. And we measured the diaphragm sharpness to say if you have a more accurate motion compensation, you should see a sharper diaphragm. Because if you are inaccurate, when you reconstruct, you'll be putting the diaphragm all over. It should spread it out, make it blurry. But if you're accurately reconstructing and compensating for the motion, you should always be putting the diaphragm in the same spot. So it'll get sharper and sharper. So this is the mixed art technique. It involves basically deforming the projections from their current phase to a reference phase. So you're taking like, let's say 5% amplitude, and that's your exhalation. You're basically taking all the projections and putting them in that state. So I'm not going to go through all the terms, but I do want to just highlight the key terms for this project. And the only things that we're changing are these vector fields, which used to be based on 4D cone beam CT, and for us are based on the 5D CT from simulation. So the way we came up with this proof of concept, it's a little tough to explain, but I'll do my best. Basically, you have about 700 projections. They're all acquired at some time, and they all have an amplitude based on that time. So what you're doing is, in the case of two bins, you're taking the 700 amplitudes and you're reassigning them either to bin 1 or bin 2. And so you have this really coarse look of it's either inhalation or exhalation, and therefore you'll have high errors. Now, as we get finer and finer, now you're reassigning them to one of 8 bins. And so you should get a little bit more info. And so with that more info, you get more accurate and sharper diaphragm. And so to quantitatively evaluate the diaphragm sharpness and put a number to it, we use this technique that Dr. Lowe came up with and published in 2017, where basically you take the diaphragm in the image and you put this profile line across it. And then this is the intensities of the profile line should look like air at the bottom here and tissue at the top, where this, I guess it's the opposite here, the tissue in the bottom, air at the top. And we fit this sigmoidal error function so that we can characterize that shape. And then we can either use this parameter, which determines the steepness of this, or we can measure the distance between the 20th percentile and the 80th percentile. So basically, the sharper this diaphragm is, the more straight up this line will be. And if it was perfectly straight, it would be like a cliff. So now looking at some of the images, On the top left, we have just a 3D cone beam CT, the diaphragm very blurry. And then as we switch from the 3D to mixed art, even with the core spinning, it looks improved. But for the proof of concept, as we go from 2, 3, 4, 8 bins, and then 1-to-1 is just using the exact amplitude. So it's like infinite binning. We get sharper and sharper with the diaphragm. So the diaphragm we use as our surrogate for accuracy because it's our primary moving boundary. It's got high contrast. It's very easy to determine this. But of course, the important stuff is the tumor and the anatomy. And so you can even see the tumor getting sharper and sharper at the boundary. You can see this vessel bifurcation in the superior edge getting much, much sharper. So we're showing that the method works and that it's a big improvement over 3D cone beam. So we did this in 5 patients just for this proof of concept study. And in all 5 patients, we could see the effect, some more pronounced than others. Depends on how much they breathe, you know. So in patients 2 and 3, I think it's pretty exaggerated. You see the 2 bins with mixed art, blurry diaphragm, and as we increase the accurate information we have, we get sharper and sharper. And then here's kind of a spotlight example of the quantitative evaluation where we have these different error functions. And down here in the bottom left is the important part where as we increase the binning, we increase the sharpness with both of those metrics. And then in all 5 patients, we have all these different 80-20 distances to measure the diaphragm sharpness. The important thing is that it goes down and the diaphragm is markedly sharper. So I want to emphasize, when is this important? The 4D approach and sorting it's not bad in cases of regular breathing. When all goes well, it works. So if you look in the bottom, you have this regular breather. You can see their breathing trace, very predictable. And then on the left, you see their mixed art with the 4D cone beam. So the original mixed art approach. And then you see ours on the right. Maybe some improvements, but you could get away with this 4D cone beam, surely. But as soon as there's even a little bit of irregularity, I mean, I don't know if you recall the grading examples in the beginning, but this is not nearly as irregular as we see breathing traces sometimes. And already you see a vast improvement using the 5D CT instead of the original approach based on 4D cone beam. So just always emphasizing it's these irregular breathing cases that create trouble, and that's what we're set out to address. So in this final study, we replaced the 4D cone beam in mixart with the 5D motion model and showed accurate motion compensation using this technique and improvements over the original mixart approach. So future directions, to get this to a clinically useful state, we need to automate a lot of the pre-processing, and that's all about time. But also another thing that we think could be pretty interesting with this that actually didn't highlight as the motivation originally, but you could use this for a gating approach. So if you picture like on an MR Linac, not a lot of places have an MR Linac, but what they can do is view the tumor and set up a gating boundary, right? So you have your gating boundary, the tumor moves in and out, you beam on when it's in the boundary. Not everybody has that, they can't see that. But if you had this, all you would really need is that belt around the patient. And then we could model kind of the same interface where now you're using the model as the patient's breathing and you're seeing the tumor move in and out of the boundary. So potentially could come up with a much more readily available method of gating. Now we'd have to get it to that clinical time frame. But we also need to come up with like a validation. You can't just trust a model for a whole course of treatment. So some kind of way we can do triggered imaging to verify it before the beam goes on. But we think this is another pretty interesting downstream avenue. And so these 3 projects all kind of come together in this adaptive functional avoidance vision. So a lot of some things stemming from concepts that are from the clinical guidelines, TG76 and things like that. But this is kind of where we and I see all of this moving towards in the future. So just kind of want to give you guys a sense of what we're working towards and what you might see decades from now. So another thing that's pretty interesting about this work is with all of that, it doesn't have to be limited to just function-sparing treatment planning, and it could go beyond that even in cancer care for like surgical guidance, lobectomies, pneumonectomies. Um, But the problem is in radiotherapy, we're used to high dose imaging protocols because it's necessary and because it's not significant compared to the treatment dose that they're going to receive. But for these surgical patients, this has been kind of a barrier. So we have done studies looking at reducing the imaging dose and seeing if we still get consistent biomechanical metrics from the reduced dose. So we've done a little bit of work here, but I think that the more important thing is beyond this where maybe we go no dose. So another recent development lately is this low field MRI. And so you can see kind of an example here of Siemens's Freemax, which is a 0.55 T scanner. They're getting incredible image quality and resolution in the lungs. It's really something we didn't have before. So can we use motion modeling and 4D MRI to get all of this information? And then in that case, we could use it for anybody that can have access to an MRI. Um, so I think this is a really key future aspect we really didn't have access to before, and now we kind of do. Um, something that we'll be working on. And then finally, I love this concept of this digital twin that has gotten a lot of steam, but I think a lot of this work fits into that. So the idea here is if you have all this kind of motion modeling, especially if it's just from CT, then it's readily available as well. You can basically create this digital copy of a patient. They come in, they get scanned, you run the model, and now you have their digital patient. And with that digital patient, you can simulate treatments and predict how well they'll respond to them. So I think this is really key for these surgical procedures where the patient selection is very, very low because they don't always know how patients will respond. And so if we have something like this, now maybe we give way more patients access to those treatments that before they just wouldn't be selected for. So I just want to acknowledge again everybody that has helped with all the work. My close advisors, Dr. Lowe and Dr. Santhanam, as well as everybody at UCLA Radiation Oncology. And I always like to pay special attention to who I call the future of the lab, which are the current graduate students, the people who are going to make this work go forward, and the people you'll be hearing from a couple years from now instead of me. So I want to thank everybody for listening. Thank you so much for inviting me. I was very happy to be able to talk to you all. So yeah, I could try to answer any questions you guys might have.
Thank you so much, sir. Thank you. That was really good. Okay.